Good morning, everyone. So today, again, fantastic lectures are going on since the last few weeks. That how to set up palliative care, how to help patients in different scenarios. So today we will listen from Priya how to set up and how to start if you want to start palliative care program in any of the hospital. So Priya is is a very good friend of mine and for everyone. I think she is a warm-hearted and always smiling person. So Dr. Priya Kulkarni, she's an excellent palliative care consultant, and right now she's working in as a palliative care consultant in Pune. She is founder of a excellent organization which is helping a lot of people, that is Ease and Support India. She is also the chapter lead of Elizabeth Kubler-Ross Foundation. And we all remember Priya's contribution as a secretary in past. She did a lot of work as a secretary for Indian Association of Palliative Care. She is true well-wisher of this association, and she is also recently we have heard, and many of us we have read, she is author of a book which she has recently launched, that is Touching Hearts Gently, by a lot of stories she has given, but a lot of information and a lot of message also with each story. So Priya, everyone is waiting for you to hear you, and Dr. Arun will take all the question answer at the end. So please keep on writing your questions and queries in the chat box, and we will sort it out, and Dr. Arun will ask at the end. So please go ahead, Priya. Thank you very much for joining us. Thank you.
Thanks a lot, madam. Arun, can I start sharing my screen?
Yes, you can please.
So let us start with this difficult part of practicing in a private setup. Really, more than a lecture, I would like it to be interactive if possible. What I'll do first is start sharing with my personal experience. And everybody is free to comment in the chat box, and we will discuss it later on once I finished a few slides I have. There are people, Dr. Geeta Joshi, Stanley sir, they have had vast experience of setting up, dealing with all the difficulties, and their inputs are going to be important as well. So let's begin. So when we are talking about hospital-based palliative care, I just thought let me just quickly Google and see what these concepts mean actually to general public, not just us doctors. So according to Cambridge Dictionary, hospital is a place where people who are ill or injured are treated and taken care of by doctors and nurses. Please read this very carefully. It is not mentioned here that they are cared here till the end, right? And according to them, palliative care means reducing pain without curing the cause of pain, or it is something that makes a problem seem less serious but does not solve the problem or make it disappear. Again, when I went through these, I was not really happy, because how can you say that palliative care is not doing enough, or we are just reducing pain without curing the cause, which is partly true. I'm not saying that they are wrong, but the other part, something that makes a problem seem less serious but does not solve the problem. The question is it really a problem, or there are other problems hidden inside as well? Anyway, when we come to giving palliative care in different scenarios, we all know from history that palliative care started with many NGOs in a hospice or palliative care center settings in India at least. So it started there. I remember long back we never had OPDs within these inpatient centers as well. Whoever is the patient, terminally ill patient, would be brought in by relatives and was admitted and can be looked after without charges till the end. Then, if the patients are coming from far away place and they have reasonable symptom management, they would opt to go home, and we used to, or we still do, help them by telephonic advice. There was a time about 10 years back or little more than that when people were struggling to fill in these hospice beds. They were free, they were available. There were few problems that there were no doctors who were interested in working in palliative care. Whoever joined would stick on for a couple of years and then decide to go out. And second is nobody would refer them to such palliative care centers. I would start with my personal story, and I'm sure you would identify with some of these problems. When we thought about it, why there are patients out in the community, all the private hospitals who are giving cancer treatment are flooded with these patients. They're not all rich patients, so why are they not coming to us? The thought process led to many things, understanding ourselves, and one of the major thing, I'm not going to talk about all the points here at this moment, but one of the things is like hospices or palliative care centers were not in the vicinity of hospital, where most of the patients, most of the curative treatment is happening. So we are not in close contact with either with curative specialists like a oncologist, or families don't know about us. Therefore, it was important to venture into their territory, to go and meet them where they come, and then start from there, which seemed logical even when we were in NGO setup and we were doing free palliative inpatient setting and some home care. So typically when you see, Arun, I'm seeing the top bar. Uh, just give me a second. So we all know and we all agree that palliative care is needed in hospitals. What all keeps happening in hospital setup? It's first patients would get disease modifying treatment. There is some management of pain and other symptoms. Are they prepared for outcomes all the time? And is there a support for family? So normally someone is not well and rushed to the hospital. These two things, that is half of the whole care which is needed for patients, is done in the hospitals. That's done very well. But what about this? Who prepares them for outcome? Is there anyone who can support family members? These are the areas where we can get inroads into, right? Any thoughts, any comments at this point? Okay. So, with this thought that we need to reach to patients and the doctors who are dealing with cancer care, I decided that I would start going to the hospitals, may it be government hospitals where a lot of cancer patients are coming from various places because they are district hospitals, tertiary care hospitals, and also to private hospital where mainly radiation therapy was happening at that time, and chemotherapy, expensive drugs, everything was being used in these hospitals. So if we go there and tell the patients and families, tell the doctors that we can help you feel better, we can really do good. And I assumed few things which were real. Like palliative medicine is a specialty like any other specialty. Everyone, all healthcare professionals know and value involving palliative care expert in comprehensive care. Because so far I have met so many doctors, and in all the discussions, in all the training programs in palliative care center, they have come and talked about how palliative care helps to comfort patients. Okay. So this was the background. I knew that they are there to help us out. I knew we have certain strengths as a palliative care physician. We know how to reduce pain and suffering. We know how to improve their quality of life at each stage. And I personally had this feeling that if you do a good work, you would be happy and satisfied contributing to their care. But soon, I was near frustration point, and the reactions were like, palliative care is giving up on your patients, and I don't want to give up on my patients. Palliative care is illegal in India. I have heard this from a relative who was treating their patient under a renowned medical oncologist in Pune not too long ago, about 7-8 years back. Palliative care is just counseling. You know, the doctors who are doing palliative care, they are trained to do medical part. They are not good counselors. One of the doctors, surgical oncologist, said, we are all doing palliative care anyway when our patients are beyond cure state. And it was like rejection from every corner where I wanted to be in. There were other challenges also, like people or community is not aware about this specialty. No one refers patients to palliative care as they know that they can do best for their patients. And sometimes oncologist assistants are as good as palliative care physicians who take all the headache of dealing with patients as well as irritable family members, and mind you, at no extra cost. You know, I'm not talking about the scenarios like Ames Hospital, which are doing excellent job and there is seamless transfer of patients between various departments. This is hardcore private hospitals. The challenge is that hospitals are not promoting palliative care. As administrators, they are not conveyed the need for palliative care properly. I have a cardiac surgeon friend who, if he meets any hospital administrator, he is wanted all the time. They would give some trade offs to him. They want him to join. But when I am going from one hospital to other, I mean, I was. It's no more a case now. Now palliative care is much wanted. And I think COVID has really helped us and helped people understand what death is and how quality of death is important. But it was the fact that time. So nobody wanted, nobody knew, and nobody was willing to introduce palliative care services. I'm sure many of you would be facing similar challenges, at least in India, in private settings. In Western countries, it's different. If you are trained palliative care physician, you would go to the hospital, you'll get a job as a palliative care consultant, you would be paid as much as others would be paid, and you would get enough number of patients coming to you for your expert opinion. Here it is different. So I thought of doing SWOT analysis. I think many of you are familiar with this SWOT analysis: strengths, weaknesses, opportunities, and threats of what we want to do, how we want to enter into private hospitals, and what are the difficulties. Strength, I said that we know our subject well and we can make a difference. But the weakness is we didn't know how to tell others what we can do is important. There were opportunities to comfort patients and family members, but the threat was nobody needed us. So, from thinking like sometimes you win, sometimes you learn, I also realized that they want to see you do good, but never better than them. And therefore, no matter how you feel, was the motto for next couple of years really. There were times when I would go, hello, you're able to get me?
Yes, we can hear you. Please continue.
Okay. So there were times that I would go and try and wait outside hospital admin, medical director, medical person's cabin, meet them, tell them, show them the presentation, how it is important to include me. They would say, we will talk to our doctors because finally they are the ones who are going to refer you the patients. Then go to another hospital. Finally, what happened, I'll tell you the story a little later. So there were funny things which were happening as I was getting into hospital consultancy. First, they would ask me how many patients you can admit every month. And the answer was, I'm not sure. If you admit one patient, how many days these patients will stay in the hospital? Again, not sure. What are the routine investigations you will advise? I mean, not just blood investigations, but CT, MRI kind of things. Any procedures you would be asking them to do? Not sure at this point. And I was not able to sell what they wanted really. But still, I didn't give up. I told them I can relieve pain. And the answer was, we have pain specialists. I can help reduce their suffering. Someone had said, we are all working for the same, isn't it? Then I would say, I can manage their symptoms till the that I can be with these patients and families till the end. But the responses were like, do you think presently they are unattended to? We have all the specialists attached to this hospital. We do not want, and this was important, we do not want patients to be here till the end. They generally go to ICU or we give them home discharge. Then I would say I can improve their quality of life. And one person had said, anyway, what do you expect from a terminally ill cancer patient to have good quality of life? It was difficult to break that. And then I realize, problems lied with our basic model when we want to go into hospital-based palliative care. If you look at this old model, it clearly showed that where curative treatment ends, palliative care started. They were stuck to this model and not evolved to the new model, which has larger sense of what all palliative care can do. We can work right from the diagnosis with them, and we can work beyond death of the patient. They were not trained, they were not ready to look for these things, and something needed to be changed. Parallelly, many things were happening nationally. I think one of the things about 3-4 years back, which really boosted people looking at palliative care differently, is the program started by Dr. Sushma and Dr. Cynthia in the hospital setting. They started training medical oncologists, radiation oncologists from the team, making them the experts who can deliver palliative care in their teams, and that has really got into the momentum. Things have changed for now. So if you look at these differences, we all know this, but just go to the last one, where we say that we can give palliative care with curative treatment. And in hospice care, they talk about it starts after palliative care ends. There we needed to do something. And how can we do that without really understanding the differences where they stand on? One of the first thing I realized that in acute care hospital, death is perceived as medical failure. People are there, we rush people to hospital ICU, and they are getting better and better thanks to advances in medicines. Because many people are living longer, maybe with comorbidities, it is difficult, and it is the perceived things, like if somebody goes to the hospital and they die and their death rate is high, then that hospital is not good maybe. In those private hospitals, number dynamics is important. How many admissions in a month, how many MRI, CT scan, and all such investigations in a month, because it drives their economical structure really. So when you try and say that palliative care can reduce cost of care, the natural expression was, who wants that? We are here to do, sorry to use this word, business of medical practice. And everything is about turnover, everything is about making more money. And are you here to reduce the costs? That was not accepted really. So then how to begin? These are practical tips, may not all work, but, and I'm sure by this time now, many of you would have other ideas as well. Can I just quickly see if, are there any comments in the chat box? I am not able to see right now.
No, not much comments. We can take it at the end. Please continue.
Okay, thanks. So then how to begin? So when you're out there to make a difference in private setting, first of all, I think you have to be convinced that there is a need for palliative care in hospital setting. When you see all this negativity around, sometimes you wonder, like, even without you, patients are being managed, doctors are doing their job, what great difference you are going to make. But first you have to convince yourself that you have a role to play, at least in pain management and end of life care. Then we have to understand the gaps in the care, which are the areas where we can go in comfortably. There is a lack of communication. I remember one of the patients, early times patients, have said to me that thanks for your time because so and so oncologist, she comes and tells us the treatment, and before we can digest what she has talked, she has gone to next patient. She is very busy. Compared to that, we can have lot of time and we can talk to them. And there is also a lack of trust because everything revolves around do this next, do that next, because they want results very fast. And then individually, you will have to design the format how you want to address these issues. It is not one size fits all, not at all. Even within Pune, I think every hospital needed to be convinced differently from my experience. So when we know that palliative care experts can act as a bridge between patients and families and busy primary care doctors like oncologists, we can tell oncologists that we can explain what you have just said to the patients and families so they understand correctly. Better communication with them leads to them agreeing for curative treatments. You have to convince your oncologist that actually whatever I am going to do is going to help adhere to your line of treatment. Till then they are seeing you as probably competitors. But if you tell them that it will actually enhance their receptivity for curative treatments, they may be willing to listen to you. And if the patient goes beyond cure state, they are not really trained, they are not interested looking after these patients. But patients keep going back to them because they don't know who else to go to. So what we can convince them that when patients reach that stage, it is possible to have this seamless handing over from treatments to from curative intent to a palliative intent if we are part of your team. Remember here, I just used words part of their team. We can't be going to their territory, if I can say so, and say that I'm another expert who can make a difference differently than you. You need to be a part of their team. When we are talking about gaps in training, we all know that traditionally we are not trained to see disease. We are trained to see diseases, not trained to deal with person with the disease, or we are not trained to reduce their suffering. I would want to have a look at this video and let's see how it helps us understand these gaps.
Care medicine. In 2008, I became a critically ill patient. So I went from being a physician and really at the end of my training thinking I knew something about what it meant to be sick, to being a patient in a hospital bed and realizing that I didn't understand what a lot of my patients had faced and what they'd been through. I was 7 months pregnant and I had sudden onset of very severe abdominal pain. What I didn't know was in that moment, a tumor that we weren't aware of in my liver had ruptured. And it was a very brisk bleed. It was like an artery being severed. And so I was bleeding very quickly into my abdomen. Within the first 2 hours, really, the blood loss had emptied my heart and veins and arteries entirely, and I'd gone into shock. The baby died, and I went into multi-system organ failure. So my liver was very dysfunctional. My kidneys failed. I had to be put on what's thought of as life support, a ventilator, and I had emergency surgery to evacuate the baby and try to find the source of the bleeding. So that initial night when that pain started turned into an ICU course that was complicated by every organ dysfunction, as well as a stroke that left it difficult for me to walk, and multiple procedures to get me well. There were a lot of things that surprised me during my hospitalization, starting from that first night when I was in the OB triage area, and one of the obstetrical residents approached me with an ultrasound machine when my lab values were very deranged to check on the health of the baby. And as he put the ultrasound probe on my abdomen, I could see the images, and I was an ultrasound trained physician. And I could see that the baby's heart wasn't beating, and I must have said that out loud because he said, "Can you show me where you see that?" And I thought in that moment that he wasn't seeing me as a patient. He wasn't seeing me as a mother who was in shock, who had just lost her baby. His perspective was really aligned on himself. And I recognized our training in that. We're trained to see disease. We're not as well trained to see suffering when it's in front of us, and we certainly aren't trained to have the skills to respond to it. I was on full support, really unable to communicate. And the first lucid thought I remember having was hearing the team in the hallway who was rounding on me. And I wanted to listen because I wanted to know what was wrong with me. And I heard them report my case in a very medical way, 33-year-old, presumed HELLP syndrome, post-op, day 3, intraoperative observation of a large subcapsular hematoma, these medical terms that I was following loosely. But then I heard the resident say, "She's been trying to die on us." And it made me really angry because as a patient in the bed, I was not trying to die. I was actually trying very hard not to die. And I felt that by saying that, by disclosing that in that way, he was declaring our relationship adversarial, that we were on opposite to prevent me from doing it. And as angry as I was, I recognized myself in that statement. I knew I had said that exact same thing as a critical care doctor. I had told my colleagues, this patient's been trying to die, perceiving myself as a barrier against their transparent goal. And I felt ashamed about that because I had never thought about that perception as a patient of what it meant to hear your doctor describe you that way. And, I really wanted to not do that anymore. We started off.
Yep. So I'll stop this here, and what a beautiful reflection, really. Each one of us would remember somebody close to us going through these stages. To be really convinced about why people like us are needed to be there in hospital setting to make a difference. So as I said before, hospital-based palliative care services are there to improve quality of care. Had somebody raised hand? I'm not able to see it. Arun?
Yeah, I would request everyone to put in their comments, please. Please continue. We'll take questions later at the end.
Okay. Thanks. So, cancer patients are more likely to stay in clinical trials, complete their course of chemotherapy or radiation, and experience better quality of life than patients who do not receive palliative care. We know that. We know from our experience that we can give better caregiver satisfaction. Are there any facts to support this? If you can go to CAPC, Center to Advance Palliative Care website, there are many presentations, and this one particular presentation, you can see the references later on, will clearly show that palliative care improves quality of life, it reduces symptom distress, and it increases patient satisfaction. It's not denying that fact. They have actually said that all across the continuum of care, like whether it is outpatient, whether it is home-based care, or patients are inpatient, palliative care reduces avoidable spending and utilization of the resources in a better way. So I think while experts are there to look and concentratedly do efforts to reduce disease-related problems, we are also there to understand patients and families' personal needs. Particularly talking about oncology palliative care integration, they need to be building therapeutic relationship with their patients and families, and it's extremely difficult when they have about 40-50 patients sitting outside their OPD. We can very well do that. We can sit with the patients who have been just diagnosed with metastatic cancers. They need time to sink in where they stand and where they need to go. There are certain tasks oncologists need to do, but they can't do justice to all of them. So, which of them put in a raid, we can easily take off from there. Of course, they have to probably reveal the diagnosis as a primary doctor. They should plan for chemotherapy, but we can help in treating symptoms. We can initiate discussions about end of life care. We can clarify patients' understanding about their prognosis. Because, doctor would go and say, okay, we are going to do this new treatment, new trial, and patient feels that it's going to help them cure. We can even help oncology teams achieve the highest quality standards for comprehensive cancer care. So this is again to highlight same thing, that if palliative care is integrated earlier on, if we can use team approach, we can help them in decision making. We can help even our nurses and other staff in the wards educate about how to ask patient about pain, how to do the scoring, when to initiate, when to give medicines. All those little things are really going to help total experience of care in that hospital, and we are indirect responsible for that satisfaction level. So though symptom management and supportive care is common, like initial slides I showed, that they also are doing same things. They are also trying to do symptom management. They are also trying to help their patients. Their focus is on cure and control, and our focus is more on survivorship and hospice care or palliative care till the end. That has to merge. So when we are talking about reducing number of admissions because of palliative care inclusion, as I said earlier, they are not very happy if you say that we are reducing number of ICU admission. If we say we are doing less testing, they are not going to admit. If we say we are doing less testing, they are not going to procedures. Again, it doesn't sound economically viable option. And if we say that we are there to reduce overall length of stay, again, they don't necessarily want that. Therefore, what we need to stress is reduced number of admissions, ICU admissions of palliative care patients where interventions are futile. They actually get same bed, same expertise to be used for potentially curable patients. I mean, we have to tell hospitals that with same set of people, they can sort of earn more, because we are there to look after patients where treatments are futile, as well as they can treat other patients who are potentially curable. Again, if expensive tests like CTs, MRIs, they are used for patients who are likely to be cured, they are likely to undergo some procedures, they are likely to be cured and going back. Let us utilize it for those patients, not for patients who are not really guaranteed of being benefited by that. And overall numbers of the hospital treating patient goes up anyway. So when we say that we can reduce overall length of stay of these patients, we can actually say that these beds can be used for patients who can give higher turnover from their bed revenue. Maybe they are able to accept that in a better way. It is just about cancer. When you are treating in a multi-speciality hospital, these are all the diseases you can make some impact into. You can increase number of OPD consultations by each patient. There are certain criteria when to refer. I think all of us can tell them when exactly they can refer their patients to us. So when we have to ask about starting a palliative care service, we have to act like a bridge. We have to be clear about our goal, but be flexible about the process of achieving it. Being a part of already existing teams is the key. Showing willingness to spend more time may help. Doing family meetings in tune with what the primary doctor wants, helping talk, helping oncologist personally as a person talk about their emotions. You know, they are also human beings. They also feel bad when their patients are not doing okay, but they have no one to talk to. We can be their friend really, and slowly you will become the key team member of these teams. So we have to recognize that we can give something always, if not medical, but we can give kindness, empathy, patience, and that warmth. We can tell them that in future, if they include us, we have a capacity to make their hospital known as hospital with a heart. So start being friends with administrators as well as with doctors. Remember why you are there to make a difference, and patient satisfaction will lead to more referrals.
Priya, you are muted. Priya, you have muted your mic.
Hello, I think I'll stop here and we'll discuss or take some questions here. Thank you.
Go ahead, Arun.
Okay, thank you, madam. There are a lot of comments. Congratulations for this nice presentation.
Thank you.
One question is there from
Arun, can you stop sharing so that I can see others really?
you are sharing. I'm not.
Okay, I did it. I did it. Thank you. Yeah.
So one question is from. So a lot of comments over there. One question is from Dr. Priya Kulkarni. The
Mhm.
experience of trying to set up home care services in a private hospital.
I mean, not service as such, but there are few patients who were converted from hospital-based palliative care consultations to seeing them at home. Some patients, and particularly if they are known to the oncologist, they are families of primary doctors. They would request if I can see them at home, but not setting up a home care service from this hospital setting, really.
Okay. Rest of the comments are actually echoing what you have already said, like very practical comments. Medical
Mhm.
oncologist says that palliative care has got no need for separate department. That is from Dr. Geeta Joshi.
Right,
Then Gaurav from Max in Delhi, he says that medical oncology is mostly a department which needs to be convinced that you can provide better care along with their care.
right.
So that is something echoing your thoughts.
Sairam, I am Dr. Nagaraju. I have got two questions.
Okay, Dr. Nagaraju has two questions. Please go ahead.
Yeah, please, sir.
One is what are the differences between how to start domestic palliative care, and what are the types of cases for domestic care, and what is the team members in the domestic care palliative care?
So domestic care is home care, you are saying, sir?
Yes, madam.
Okay, so I mean, though this is not a topic to be covered here, just to tell you from my experience or others may share, I think exactly as I said, there are difficulties for setting hospital-based palliative care. I think you need to be convinced that you can make a difference. I think the channel or the way you have to go through is probably to go through general practitioners in the locality, because towards the end these patients are being treated by GPs. So if anyone else have any other comments, they can
Dr.
add.
Mohan is there. Dr. Mohan is there in the audience. Can support
Yes,
from
ma'am.
Can support. He can answer because they have a lot of experience of home care. Dr.
Uh,
Mohan, please.
yes, ma'am. You see, referrals can come from hospitals also. There could be referrals on your helpline. There could be self-referrals from patients. So these are three ways we can get our patients. When you initially start, most of the referral will be from the hospitals. And when you grow up, then it can be referrals from the community itself also. Even from some GPs, uh, people go less often to GPs. That is our experience. Hospitals need to be, you need to network with hospitals so that you get more referrals when you start your work. That's all I have to say. Thank you.
Arun, next
Um,
question.
Ma'am, there are no questions. There are many comments. I'll read one or two comments then. So there are really no questions. I mean, whatever you have said is so practical and people have really appreciated that.
Thank you.
And yeah, so so people have shared, Dr. Lulu Matthews, she has commented that palliative care team can talk about, they can also initiate advanced care directive preparation.
Yes.
They can take up bereavement visits, grief counseling, which oncologists are not comfortable with, and maybe that will help them to integrate more into the care. Dr. Preeti Gautam has shared that the amount of satisfaction that doctors feel even after taking care of terminal patient is so much, and it is quite good when you get bereavement when you do bereavement care and get calls for appreciation after the process has been done. So that is a matter of satisfaction, which is definitely, I think, everybody will share. Dr. Malika says that including palliative approach actually enhances name of the hospital. This kind of approach to the hospital management might help to gear up palliative care practice. Lulu Matthews, madam, also says PC team can request private hospital to set up private end of life rooms where all non-intervention management will be done. For
Okay.
example, no artificial ventilation, no parenteral nutrition, etc., etc. I'm not sure if this point has not been kind of discussed. What do you think about this? Like,
I mean, I have seen having a separate section within the ICU in AIMS, they call high dependency or something. Madam, Sushma Madam?
It is not for end of life care, but definitely there are separate rooms where people, those who are dying, we don't provide extraordinary technological advancement care, but definitely we counsel them. And as soon as the relatives and if patient can understand, they are convinced that they can take care of their patient at home and they feel empowered, we try to send them home. There are few certain group of patients, they don't want to go home, so we allow them to die over there, but very rarely this happens.
Right.
So basically we have to create a separate area in a private hospital also. If there are 2-3 rooms like this, I think this will be a great help for develop your it's like patient, they will not like to go home uh, if they are not very confident that they can manage their patient at home. So till the time they feel confident enough, they feel empowered, I think there is a time we need, and there should be a separate area. We cannot care them at the acute care area, otherwise everybody will see them and they will say that these doctors are not doing anything. We should not keep them in ICU, so there should be an area. So in a corporate hospital, everyone should try to develop that area. In the government hospital, they should try to develop this area. And always our aim that should be that patient should be managed symptomatically, absolutely as best as possible, and relatives should be taught that how to take care of this patient at home as best as possible. So these are the two things which we do routinely. And if other comments are over, I want to give a lot of comments for this lecture also. So I will give
Sure, ma'am.
at the end if there are no other comments.
something from
Yeah,
Stan.
Dr.
Stan, yeah.
Stanley is, Dr. Stanley, please.
Thank you, Dr. Priya, for bringing out that excellent difficulties that is involved in integration. And I think you have brought out this point about hanging on, hanging in there, because this kind of integration is a very slow process. And there's a term called resilience in palliative care. And this is what all of us have to be familiar with, that there'll be many barriers, many problems, but keeping the patient suffering, we have to keep on at it. We have to make the difference. And when we show that, even in one patient that, to our colleagues that we have made a difference, then slowly they begin to understand what it is. And
Right.
so I think continuity of care, as a seamless care is very, very important. So in our Indian context, we have basically two models. One is the hospital model and the other. So in a hospital model, fully integrated model is important, starting with clinics, everything, ICU interactions, everything. In every area, there has to be integration. And the other model is the model of good networking. You may have a certain aspect, but you network with all the other requirements properly. And with these two, we can provide that kind of a seamless care. So thank you, Priya. Thank you very much.
Thank you, sir.
We have 6 minutes left. Dr. Sonali Kulkarni, would you like to say something?
Yeah, definitely, sir. I am from Sipla Palliative Care Center, and I have worked with Dr. Priyadarshini Kulkarni for many years. But presently, we are connected to the many hospitals in Pune. We are basically cancer treating hospitals, but they are the trust hospitals. So since last 2 years, we are the part of them, like Indrayani Hospitals, Asun Hospital, and many other hospitals. I think we don't wait for the referral getting from the oncologist, but we are concentrating on each and every staff of that cancer hospital will get aware of the palliative care services and what it get benefited for the patient. So it will help us for getting more and more referrals. For the last year from Indrayani Hospital, I think on the external OPD, I have seen near about 550 patients from that get from that hospital for the palliative care services.
Thank you. Thank
So
you very
building a network is a good idea for getting in that hospital.
Very good.
Yes, thank you so much.
Congratulations.
Dr. Bhatnagar, please. There are no more comments.
So, okay, sorry. So, Priya, thank you very much, first of all. Everything, whichever you have said, I think it was coming right from your heart and your experience, that what exactly struggle you have, everybody has to go. Unfortunately, palliative care, if you want to start in any of the hospital, you have to go to the same boat. You have to go through the same struggle. Only thing, the struggle will be varied from place to place and from people to people. In corporate hospital, like my residents and all, they are struggling in a different way, and in the government hospital we struggle in a different way. So we have to struggle, but I can assure you that the way we are going, the whole India is going, the day will come when everybody will say that we need palliative care specialists in our team. And this I can say with my own experience at AIMS. Within two within means, like, I think hardly there was any time. I think with last 5 years we have started working. Oncologists, they accept us like a team member. We have a joint cleaning, we sit in the DMG, we have a everything, we are together. So oncologists, there is no need to say that we have integrated completely. But in non-malignant patient, I feel so overwhelmed when a neurologist is asking me that somebody from palliative care team should sit in my clinic. And now there is a competition that where should they, because we are sending only one palliative care physician in their team, but they want that, everybody wants that their palliative care physician should sit in their clinic, because they have realized the importance of it. So there is no there is no need to say that palliative care is important. And it is not, it is beyond counseling, because it's not only counseling which we are giving. There is lot more things we are doing with the physical symptom management, with making their goals of care, and whatnot, everything Priya has said. So I think we should not get disheartened. Only thing, a person with a good attitude and committed people with dedication, we need people like this. And the people, those who are attending this lecture, I think if they are attending at 6:30 in the morning, they are dedicated. So we should not get disheartened. I'm telling you, if we will go with this speed, within 5 years, you will realize that every hospital will like to have a palliative care setup in their hospital. And all our palliative care physicians, those who are completing their MD palliative medicine, they will be placed in various renowned hospital. So only thing, we have to understand the science behind it. We have to understand the medicine behind it. And we should come with our shell that it is only counseling, and it is only caring for a dying patient. This is our feeling also. We keep saying that people understand palliative care is only dying care for dying, but even our people, they have a lot of 50% of people still think that counseling and caring for a dying is palliative care. But we have to come beyond this, that we can do a lot of difference right from the beginning if we will integrate. And I'm so happy to tell you that patient with muscular dystrophy, patient with epilepsy, patient with the neurodegenerative disorders, patient with pulmonary acute interstitial lung disease. I think all of them, and patient with congestive heart failure, they want that these palliative care physicians, they really make a lot of difference. And we are sending our juniors doctors, means like MDs, and they are making a huge difference in their ward, and they realize that this is a difference they are making, and they want that they should sit with them in the clinic. See, the senior most neurologist, senior most cardiologist, they want that they should sit with their clinic. So this is the way things will develop. But friends, we have to keep working hard, because it's a new branch. And it was an stigmatized branch since beginning, that when patient is dying, you need palliative care. And we have to come out of it. We have to remove this stigma, we have to remove these myths, and we have to keep working hard wherever you are working. I'm telling you, if you will make a difference in a single patient's life, it will go a long way, and people will listen you. And you have to keep proving yourself that you can make a difference in medical science in their patient. And this is the only way. And I think I'll request again, once again, that we have to make it a medicine branch, not only the counseling branch. So we have to, counseling is an important part, but it is also a medicine, it is also a science, and we have to put science and medicine in this, so that people, because now people will listen only the arguments, only the evidence, and you have to keep creating evidence that you can make a difference in their patient right from the beginning. It is not at the end you are required. Thank you very much, Priya, for wonderful lecture and wonderful experience which you have shared, and it was too good. I think everybody has enjoyed, and there are a lot of comments. I will request Nisha to send all the comments to you so you can treasure these comments in your this thing. And thank you, Arun. Thank you very much.
Thank you.
For every Monday you are taking care of the coordination part so nicely. And thank you, Nisha, for keeping everybody else on track. And Nisha keeps reminding that there is a lecture at 6:30 in the morning at 7 on Monday. And we'll all see you next week on Monday before 6:30. Have a nice week. Thank you very much.